You are not.
Good morning, all. Another Monday. How's everybody doing? Only what, 5 weeks? 5 weeks left or so? It goes fast. Did you guys survive Friday? Yeah? Barely. Oh well, it's done. Start fresh. Okay, so we're going to finish GERD and PUD today. Thursday, Jacob Carr, who's a resident, is going to do the acne, tinea, and eczema, and then I will be working on the Exam 3 study guide and all that, so I'll get that to you hopefully before Friday because I'm lecturing to PA students on Friday. So I'll get that to you. Any questions at all about anything previous in terms of pharmacology or constipation, diarrhea, IBS, the other one? No? Okay. So I'll get the study guide to you guys so you know what to focus on. I'll try to focus here too. And it should be pretty similar to the last one, probably less cases. Because asthma and COPD had a lot of cases. Probably not as many cases, and should be about probably less questions. Okay, so now that you've got the pharmacology of GERD and PUD, we'll go into the therapeutics. With my luck, there were 2 new guidelines that got updated in 2024, so I was busy over the weekend trying to get all that new information because DePiro is a little old in terms of their information on certain aspects. So there's going to be some stuff in here that's brand new. So let's just get into the objectives are there, and we'll get into GERD. So I'm sure many of you have had heartburn. And probably reflux. How many have had like heartburn and reflux? A lot. Yeah. So basically the difference between heartburn and actual GERD is that it has to really happen at least twice a week and also really damage your quality of life. So that's the difference, it really has to affect your quality of life. So in terms of GERD, the symptoms, basically you're refluxing acid, pepsin, bile acids. So basically it can be anywhere, esophagus, lung, mouth. And in terms of the way it happens, it's generally, it can be in childhood and develop, but it also is most common in older patients. And usually men are more than females in terms of severity of GERD. The risk factors you can see here, it seems to be the same risk factors for a lot of disease states. Obesity, smoking, alcohol, definitely specific medications and foods. And in terms of respiratory diseases, we talked about asthma and GERD, and that's definitely about 50% of asthmatics a lot of times will have GERD. And in terms of the pathophysiology, it essentially is because of the sphincter. The lower esophageal sphincter pressure, it actually is affected by gastric emptying, it's affected by age. So as you age, the pressure decreases. Intra-abdominal pressure also will affect that sphincter. So in terms of not only the pressure of the sphincter so that it will open and then reflux those contents, but there's also the mucosal defense of the stomach itself. And that is going to be decreasing and also ineffective because of gastric emptying is motility is going to affect the mucosal defenses against the acid. The biggest determinant, I guess, of severity is the composition of the refluxate, the volume that you actually are refluxing, and then the duration of exposure. So essentially how long it's actually in the esophagus and in the lining. In terms of, there's an anti-reflux barrier. It's at this esophagogastric junction, and that is really what malfunctions. And then basically that's all due to that lower esophageal sphincter pressure that's decreased, and also then on top of everything, the mucosal defenses that are decreased. In terms of, another factor is you swallow. So saliva is very beneficial, and as you age, it decreases. So saliva contains bicarbonate, so that neutralizes acid. So that really helps in terms of, preventing reflux and damage. So everything as you age decreases, so that basically is what happens in terms of the pathophysiology. In terms of clinical presentation, you essentially have symptom-based, which is heartburn, regurgitation, belching. Belching is generally swallowing air. Smokers basically will, because you're smoking, it causes you to swallow air, and that can cause belching. Reflux chest pain. So a lot of times it's mistaken for angina, right? People come in and essentially, they think they're having a heart attack and they actually have heartburn. In terms of tissue injury based, essentially those are all the complications that can occur. So GERD in itself is not, it's not going to kill you. It's very uncomfortable. But if it gets into the tissue injury based complications, then it really will affect your quality of life. And the problem is GERD can also, if it's really, really severe, not treated, can actually lead to cancer, esophageal cancer. And also, when we start talking about peptic ulcer disease, between GERD and peptic ulcer disease, it can lead to gastric cancer. So essentially, it's something that you cannot, ignore. Esophagitis, strictures, Barrett's esophagus, and esophageal adenocarcinoma are the real complications that essentially will then mandate therapy for life, because basically it's something that is going to affect the actual tissue and cells in the esophagus. Extra esophageal symptoms that also are going to occur are like a cough, you have laryngitis, you lose your voice, sore throat, but also, the asthma. Like I said, 50% of asthmatics generally will have some type of reflux. So those are just things that people will present with in terms of severity, but the alarm symptoms that you really have to watch for, where you cannot basically take care of that patient, you have to refer them, is essentially dysphagia, so trouble swallowing, pain on swallowing, bleeding, vomiting, any type of unexplained anemia, because you're losing blood, right? It's bleeding, and also unexplained weight loss. So all of those are alarms of symptoms that really have to be, it means that you are getting into that tissue injury-based GERD that essentially now is complicated. So you definitely have to refer anybody with those alarm symptoms. So definitely know those alarm symptoms. In terms of complications, we listed some that were in terms of the tissue-based injuries. So those are all the complications that will occur with, remember, the volume and the type of composition for that refluxate, which, can be pancreatic enzymes, can be bile acids, the hydrochloric acid from the stomach, and pepsin. Okay, so all those things combined. So esophagitis is really, you're getting inflammation of the lining because you have really long exposure to that refluxate, right? And so that erodes that whole epithelium of the lining. It's called erosive esophagitis, so you have non-erosive reflux disease and also erosive, and this is where it gets into the complication. Strictures basically are all caused by scar tissue. So think about it, if your lining is being damage. You're getting scar tissue, not only because, also because of the immune system working to try to repair that lining. So essentially, you'll have narrowing. And then Barrett's esophagus, that's where actual squamous epithelial cells in the lining are replaced by columnar type epithelium, which makes it even more rigid, essentially you are damaging, it's fibrotic, just like we talked about pulmonary fibrosis, same thing happening in your esophagus. And think about an esophagus, if it loses, like its elasticity, it's not going to function, it's going to keep narrowing, and you're not going to be able to swallow. So that, you can see the risk factors for the Barrett's esophagus, and that's something that is treated for a lifetime and may need surgery. Esophageal cancer, basically, if it's bad enough, it will lead to esophageal cancer, which then has to be treated. And really, these two are linked, the Barrett's and the cancer. So that's why you really have to treat them for life. In terms, there's no gold standard for diagnostic testing. So basically, a lot of it is due to symptoms, right? You basically are looking at people's symptoms. Generally, they will empirically treat with a PPI, proton pump inhibitor, for 8 weeks, okay? And if then, essentially there's nothing happening, no response after 8 weeks, then they definitely will go into some of the diagnostic testing to essentially find if there's any damage, basically what is going on in terms of the esophagus. Because the symptoms don't always correlate to the severity. And a lot of times you might have a normal endoscopy but still have symptoms. So that's why there's no gold standard diagnostic tool, but upper endoscopy essentially is the most diagnostic in terms of seeing any damage to the esophagus. Then in terms of the next favorite in terms of testing, the manometry, it's not used alone, it's used after the upper endoscopy, but essentially that will actually identify motility abnormalities. So like we were talking about gastric motility, that can affect how basically the lower esophageal pressure and also just the functioning of the gastric emptying. If you're not emptying, you've got that acid accumulating and then refluxing. So that will actually measure the motility of your stomach. And this is basically just a visual of what a person will go through. And in terms of after the manometry, you can also do ambulatory reflux monitoring, where it actually is going to, for 24 hours, they monitor the pH and how many episodes you have in 24 hours. And you basically have, you're hooked up for 24 hours, and essentially the acid exposure time, so AET, and I have that in your little notes in your slide. Basically, you're measuring how the percentage of time that the pH is less than 4, and essentially normal is going to be there for about 4% of the time. It's going to be at less than 4 in terms of pH, but you're also looking at the episodes, how many there are in 24 hours. And you don't have to know the normal and abnormal. I'm just sort of giving you how they measure the refluxate, and knowing that the acid exposure time is really the important factor in terms of how long you're exposing your esophagus to that acid. And then essentially combined impedance pH monitoring, that actually is going to do the acid and the non-acid in terms of the refluxate. They basically are measuring anything that's then going to irritate that esophagus. So in terms of all of those, they're not specific diagnostic tools, but it's something that if somebody does not respond to a PPI for 8 weeks, then they will look into them getting into testing. And they definitely are getting into testing when they are doing it to make sure that they don't miss those complications, Barrett's esophagus, etc. That is really where you really need endoscopy and biopsy. They also will do biopsies when they do the endoscopy in order to really see what's going on in the esophagus. In terms of goals of therapy, there's patient-oriented, of course, decreasing and eliminating symptoms and preventing complications, and also disease-oriented. So most of, there's different drugs, but the big thing is to decrease that acidity of the refluxing. And then also the gastric volume of the refluxate, so it doesn't go, basically there isn't a lot of acid that's there to actually reflux. Improve the gastric emptying, increase the LES pressure, and then really try to increase that clearance of that acid, and then protect the mucosa. So most of it is acid suppression. That's the biggest thing that you want to do. In terms of the treatment, the general approach to treatment is first self-directed therapy. I mean, the one problem with GERD is most people will not really report it, right? They're not going to go and talk about, GERD to a doctor. They'll probably go to their, to the retail pharmacy, and they'll pick up either, antacids or the histamine 2 receptor antagonist or the PPI. Now that we have so many PPIs that are over the counter, they just basically will go, and that's really the one that's used the most now. But they don't know some of the problems with using it long term. So in terms of first, there's self-directed therapy, so they have lifestyle changes that we'll go through, but essentially the lifestyle plus the over-the-counter medications, those specifically should only be done for 2 weeks without them being seen. So if they don't respond, to medications with, in 2 weeks, then they really should at least be seen by a provider, so that they can, first of all, be directed to the proper therapy, but also possibly prescription therapy might be needed. And that's really generally higher dose, more frequency. Okay? So in terms of antacids and the histamine receptor antagonists, those can be given to children, anybody at least 12 years of age. When we're talking about over-the-counter PPIs, we generally are only going to be recommending them for adults, so 18 years and older. The big thing about lifestyle changes is they should be individualized. So in terms of, there's a table in DiPiro, you don't have to memorize or anything, but just sort of be aware of the lifestyle changes that are necessary. But you don't have to memorize that table, but that will give you specific lifestyle changes. The big thing with, this is all sort of increasing in treatment. So you start out with lifestyle and over-the-counter. You then, basically go to pharmacologic treatment, which basically will just increase the frequency and the strength of the PPI, and then possible surgery. So like when you start getting into those complications, you essentially you might have to get into surgery, in terms of if all the cells have changed, you're narrowing the strictures that have to be, basically taken out because essentially your esophagus has become so narrow you can't swallow. So that's sort of the general approach in terms of, the problem is with PPIs, if you use them a long time and then you don't use them, it's acid rebound. So that's something that people don't recognize. People think PPIs are very safe and you can use them forever. But unfortunately, there is an acid rebound if you use them and then stop them abruptly. So that's something that people are not aware of for self-directed therapy. And also, in terms of just you really want to have like a step-down approach. You want to try to step down to the lowest dose of a medication as possible, starting with a PPI because they're the most effective, and then maybe then going to a histamine antagonist. But in terms of what is going to be used, it's all going to depend on the severity, the frequency of symptoms, the degree of esophageal damage, if there's complications. So that's all going to determine what you actually will use. Now, in terms of non-pharmacologic recommendations, weight loss is a big one. You know, if you think about it, if you're obese, you know, you're putting pressure in terms of, you know, that low esophageal sphincter is going to be, you know, affected in terms of the pressure that's on it. The big thing is elevating head of the bed and sleeping on your left side. The reason you sleep on your left side is because it actually increases stomach emptying. It facilitates stomach emptying. So when you're sleeping, it's better to sleep on your left so that your gastric emptying is going on as you sleep, and you want to be elevated so that you're not sleeping horizontally and that acid is just sitting in your esophagus. This is just an actual commercial reflux tool, you know, that you can use to actually elevate yourself and sleep on your left side and essentially prevent any of the reflux symptoms at night, which do occur. The big thing about including a protein-rich, low-fat meal, fatty meals will actually decrease the lower esophageal sphincter pressure. So you want to, and you know, protein actually will increase it. So you want to eat protein and low fat, which is healthy anyway if you're trying to lose weight. So, and a lot of behaviors that you have to do, you have to sort of augment how you eat, etc. You want to eat small meals and avoid meals within 2 to 3 hours before bedtime. So that's something to prevent that gastric acid from being produced and secreted while you're sleeping. Avoiding alcohol and carbonated drinks, avoiding smoking, avoiding citrus because it's acidic, right? It's an irritant. So any kind of citrus, any tomato, orange juice, any juices, they're acidic. That's another thing you need to sort of avoid. In terms of tight-fitting clothing, so that you're essentially not causing discomfort and also increased pressure. And then always taking drugs standing or sitting, and don't take them right before bed and then lie down. Because then, you know, especially like if you're taking a non-steroidal or aspirin, low-dose aspirin at night for preventative, you essentially, you know, might sit in the esophagus and be an irritant. There's the table in DePure is really good too because it really does trigger medications. So there are certain medications that will decrease the LES pressure. So essentially things like barbiturates, anticholinergics, caffeine does that also. And then in terms of the other mechanism is it's going to irritate the mucosa, like I was talking about in terms of iron is one. So if you take iron supplements, that could irritate the esophageal lining. Also, I was talking about tobacco, of course, so smoking, and then we were talking about the non-steroidals and aspirin. And spicy foods, that's another big thing. You know, you want to eat more bland foods because spicy foods can be very irritant to the esophageal tract. So those are just some of the lifestyle changes that you really want to tell your patient, because a lot of these lifestyle changes may be all that they need. They might not necessarily need, you know, a medication if they, you know, look at, if it's not severe, if it's mild, then they can just take care of it by lifestyle interventions. Now, you don't have to know this by heart or anything like that. This is just the chart from the over-the-counter handbook about treating heartburn. Okay, so self-directed therapy is really just for mild heartburn, and that's where you are doing lifestyle and OTC therapy for 2 weeks. Okay, in terms of, at least, you know, do know when you have to definitely refer somebody. If somebody comes to you and they want some assistance in starting the acid suppression therapy, you know at least the exclusions for self-treatment so that essentially you know, wait a minute, this person really needs to be referred. They really shouldn't be taking it without being, without at least seeing if they need a test to see if they have any problems. So frequent heartburn more than 3 months, heartburn while taking actually the over-the-counter products. you basically have nocturnal heartburn. You have vomiting, blood, or black material, which is definitely indicative of blood and bleeding. So any of those on the top there, just at least know the exclusions to treatment to know, okay, this person really shouldn't just be taken over the counter and be left without any kind of help. So you can see that treatment for self-directed treatment is really just for essentially episodic heartburn and only like heartburn itself. It's not diagnostically gastroesophageal reflux disease. It's just heartburn. And essentially, you essentially will want to resolve it within 2 weeks, and if it doesn't, then definitely be referring them. So that's just sort of the self-directed therapy. So if somebody walks in and hasn't had therapy, you can recommend the PPI or H2RA. Antacids are used specifically. They move from antacid to H2RA and then essentially to the PPI for mild to moderate, heartburn and GERD. So you essentially will want to understand, when you can recommend treatment and when you should refer them. In terms of antacids, they're really the first line for really mild, intermittent symptoms. So essentially, if you have, certain foods that cause indigestion, you can use an antacid. The thing about them is they're very quick acting, but they don't have any duration. Okay, so they're going to increase that intragastric pH. And, the one thing you do have to really understand that you really can't suppress acid or protect in the evening for bedtime because they just have such a short duration of action. So you're not going to be using this for bedtime symptoms. So in terms of the, drug itself, the antacid itself, they don't have a lot of side effects, but they do have a lot of clinical drug interactions because you have to make sure, think about it, you're increasing the pH, right, of the gastric environment. And a lot of drugs need an acidic environment to be absorbed. They also provide like a physical barrier. They sort of coat the lining, so they provide a barrier to absorption for drugs. So with drugs, you really want to administer the antacid 1 to 2 hours before or 3 to 4 hours after medications, just to prevent that, because it basically will not only increase the intragastric pH, but it'll also bind the drug. It can cause a complex with the drug. So you really have to, all these drugs basically can either, be affected because of the pH of the environment, so there's less absorption. They increase urinary pH, and also gastric, and also then cause complexes to form. In terms of some of the cautions, aluminum can cause constipation, the magnesium can cause diarrhea. So you definitely want to look at that. And also for elderly, the aluminum may cause bone demineralization, so you want to make sure that you are using it with caution in elderly that have osteoporosis or any risk of bone fractures. So in terms of this one, this is your immediate relief drug that is really just for symptom relief for mild intermittent symptoms. In terms of the common products, you don't have to know this table by heart. These are just a list of some of the common products, what they have. You can see most of the antacids. One thing, just know what's in an antacid. So essentially, there's sodium bicarb, there's aluminum, there's magnesium, there's calcium carbonate. Okay, so those, if you in a test, you basically, if I say antacids or if I say calcium carbonate, you'll know it's an antacid. Okay, so you don't have to know any detail, just know what antacids really contain. Bismuth, bismuth, subsalicylate. That's also Pepto-Bismol. That's another one. That basically that we'll be getting into more with PUD. That's something that you have to really watch with people that have allergy to aspirin, right, and salicylates. So and also renal function, because it accumulates in renal insufficiency. So for elderly, the bismuth can actually accumulate. So these are things that you have to sort of be aware of with some of the ingredients. Same thing with aluminum and magnesium. Renal insufficiency is a big problem in terms of accumulation. So you want to really make sure that, if somebody, especially an elderly person with any type of renal insufficiency, is taking an acid, they're monitored because of that accumulation. So the next line of attack, the second line option, is the H2RA, the histamine 2 receptor antagonist. Really, it also is only used to mild to moderate, so it's not going to be used for your really severe GERD. Just like the antacids, they all have similar efficacy. So they all, basically will increase that pH. They essentially diminish gastric acid secretion. So essentially, they are actually not only, helping to increase the pH because they are diminishing that gastric acid secretion. And the thing with the H2RAs is they have a longer onset of action, but they have a longer duration. So they can actually be used at night for bedtime symptoms. And a lot of times they will be used specifically for nocturnal symptoms. In terms of the one thing, because they will diminish gastric acid secretion, they have to be taken before a meal. Okay, so you have to take it before a meal. And generally for mild GERD, just for GERD, you're starting with the H2RA before the PPI. They have essentially, less side effects. They also are less likely to give long-term side effects, but they basically are used second line after antacids. The one thing that is a problem with H2RAs is tachyphylaxis, where they basically, with successive doses, there's a decreased response. So essentially with H2RAs, if you use them all the time, you'll probably find a tolerance developing where, you essentially, it won't be as effective over long term. So they are not used for, for life generally because of that. But it's something to be aware of if somebody says, oh, they've been taking, Motadine and it just isn't working as well anymore. It's because they're diminishing response to the successive doses. The one thing I wanted to point out, which I'm sure you guys know by now, but in 2020, ranitidine was taken off the market because of cancer scare risks. So essentially now, unfortunately, they did the brand name exactly the same as ranitidine. So famotidine now is the H2RA that's most common, and unfortunately they use the same brand name. So it's basically Zantac but with famotidine instead of ranitidine. So you're not going to, I'm not sure in your top 300 if you still have ranitidine there, but basically it's not used. Now if you see, you might have people that actually still have it, because, had it in their medicine cabinet even though it was discontinued. So if anybody does have ranitidine that you see, you just tell them don't take that because of the cancer risk. In terms of the products, you can see here there aren't as many, but essentially cimetidine really is not as commonly used because it has a lot of drug interactions. So famotidine is really the drug of choice for H2RAs. You don't have to know, brands, and I'll provide brands and generics. But essentially, the one thing that you'll see in Pepcid Complete, the H2RAs often are combined with antacids. So you use the antacid and the H2RA. So you could use the antacid for immediate relief, and then maybe the H2RA for nocturnal symptoms. So you can do that successfully. In terms of going prescription, the only real difference is you're going to twice-a-day therapy as opposed to once-a-day therapy. So over-the-counter H2RAs will be once daily and then increase to BID if they're a prescription. Highest relief rates, okay? They also have similar efficacy. The problem is they have a really wide variation in intragastric pH effect. So that is the rationalization for switching to a different PPI if there is incomplete response to one. You can, even though they have similar efficacy, they have different effects on the gastric pH. So you can try to switch to a different one if one is not working. The onset is longer and the duration is longer, so 24 hours. So they are dosed once a day for over the counter. And it's really used for the moderate to severe symptoms, so greater than 2 times a week. And also if there's any type of erosive disease that we were talking about in terms of esophagitis or strictures or any of that, Barrett's esophagus, things like that. In terms of, like I said, they are given empirically first. If somebody's really severe, generally they will be given empirically first for 8 weeks to see if they respond. And if not, then they go through all that testing in terms of finding if there's some kind of other complication, or if it's not GERD at all, it's something else. So when they talk about empiric therapy, they are talking about using PPIs. The twice daily PPI use is indicated if they're not responding to OTC. So that's the prescription strength frequency. Optimization, what that means is essentially before you start increasing and changing, first look at how the patient's taking it. Even though PRN PPI has been shown to be as effective as taking like once a day maintenance PPI, still, if somebody's on a PRN PPI, you would then move them first to a daily, so they're taking it consistently to get that acid suppression before increasing them, in dose, or possibly switching them to another PPI. So that's what optimization is, and also when they take it, because you really need to take it 30 to 60 minutes before your largest meal of the day, okay, which it could be breakfast. For me, I don't eat until like noon, so, whatever your largest meal of the day is, that is really when you want to take the meal. And if you are having nocturnal symptoms, it may be in the evening, like before dinner, because that way you're going to protect yourself throughout dinner. Now, can you take both PPI and H2RA, like take your PPI maybe before your first large meal of the day, and then take H2RA at night for the nocturnal symptoms? Yes, you could do that, because that would at least take care of those 2 instances. If you're having symptoms throughout the day, you don't really want to wait until evening meal to actually take your PPI. So you can actually take, both of them if needed for that nocturnal symptom. Now, the big thing with PPIs are you are going to start them on a low dose, and essentially if there's response, you're going to try to wean them off of the PPI. And you really don't want to increase unless they really are not responding and there might be issues that are like complications. Because basically the biggest problem is, you can have that acid rebound effect, and that is something that is going to really affect the healing of, for GERD, or, the symptom severity. So why are we so concerned about, stopping PPIs and also using them long term? They have very common adverse effects, really very similar to all the other gastric products: headache, dizziness, diarrhea, constipation, flatulence. That's a given. It's the gastric area. Nausea, vomiting, and abdominal pain. So those are just common adverse effects. The one thing about PPIs that you don't see with H2RAs or antacids is the long-term adverse effects. If you're taking them you know, like I said, empiric therapy is 8 weeks. Now, it could be up to 12 weeks for refractory GERD, or complications, like I said, could be long-term, could be throughout life because of the complications. So long-term, within the first month of therapy, people are at higher risk for pneumonia, community-acquired pneumonia. Remember, you know, how respiratory diseases are sort of associated with GERD. And then enteric infections, intestinal infections, you know, because basically the alteration of the gastric environment to a less acidic environment can also spur, you know, bacterial growth. So you have more intestinal infections. Vitamin B12 deficiency and hypomagnesemia, you know, think about, you know, the gastric pH in terms of how it's being affected. Absorption of vitamins and minerals and things can be affected. Bone fracture, you know, that's another big thing in terms of elderly, especially osteoporotic elderly. Chronic kidney disease and cardiovascular events. So those are all things that if they take them for a long period of time, they could be at risk for some of these long-term effects. So that's why you want to get people off of them if you can, if they really don't need to be on them for life. The big thing about, you know, Clostridium difficile, so, you know, not only are you going to have GERD, you basically are going to have just terrible diarrhea. So essentially, because of all that downstream effect on bacteria and the, you know, it's creating a good environment for bacterial growth, Clostridium difficile is one of those that tends to start and is more at risk for colonizing. Because they reduce the acidity and affect the absorption of all of these medications, nutrients, etc., especially antifungals that need acidic environment, you know, you really have to look at the drug interactions when you're giving PPIs. And the one big thing about omeprazole, which you really need to know, is that it inhibits CYP2C19, so it will decrease the effectiveness of clopidogrel. Clopidogrel is an antiplatelet drug that's used when patients have stents. My husband, who had stents put in, was on it for a while, bleeding all over the place. But basically, it will, you know, decrease the effectiveness because it's inhibiting that prodrug from being converted, because it's an inhibitor of the CYP2C19. So that means you're more at risk for clots. Okay, so basically, you really want to, you know, make sure that if there's anybody that's on clopidogrel, you're not giving them omeprazole. The other ones don't have that problem. So, you know, it's just really omeprazole that's the issue in terms of this one. The other issue is gene variations for slow metabolizers. That's really more apropos in Asians, more than anything in terms of gene variations. So you just have to be aware that if you have a certain, you know, culture, and also if the person's on a certain drug, don't use omeprazole. Choose a different one. In terms of the deprescribing, you don't need to know this. I just wanted you to see how complicated it's not titration, it's actually deprescribing, but essentially you're basically titrating down, okay? And this is the amount of weeks that is necessary to prevent that acid rebound, okay? Even if you can, sometimes even if you miss some, for some people who are very sensitive, if you miss a day of a PPI, they might have acid rebound. But here, if you're on a PPI for a long period of time, you essentially want to really, you know, decrease their dosing gradually so they don't get that acid rebound. In terms of, you can see every 2 weeks you're decreasing the dose by half. Then you're alternating the PPI with the famotidine so that you're getting at least some therapy with the H2RA as you're decreasing your PPI. So this is something you know, just sort of have to be aware of if somebody's been on a PPI for a long time, to not just say stop it, because they may then get that acid rebound. Now, you're never going to deprescribe for the complications. So for any of these, you're going to be treating them for life generally. Unless maybe surgery was successful and they don't have issues, but essentially you don't want to decrease that PPI for anybody with those complications. So these are the OTC options. You have the omeprazole, lansoprazole, and the esomeprazole. And you don't have to worry about knowing all the details, but just remember, you're always going to give them 30 to 60 minutes before your largest meal. Some people do that intermittent fasting, so it wouldn't be a breakfast, would be whatever their largest meal is of the day. And here, remember, for OTC, it's once a day, so it's going to just be 1 capsule or tablet. That's the maximum. Now, when you get into the prescription, the red ones are the ones that you should know. I believe they're on top 300, but essentially, these are the most common used in terms of prescription products. The big difference is you're using them BID, not once a day. And they can actually, remember, over-the-counter PPIs can't be used in children. Prescription-wise, they can be, if they are prescribed by a provider. So essentially, that's just the one that has both the antacid and a PPI is the Zegarin. Generally, they will really combine antacids with H2RAs instead of PPIs, but that is one that does have a combination product. Okay, other considerations, basically for maintenance therapy, you really are going to have maintenance only for those that have continued symptoms after the discontinuation of a PPI, and erosive esophagitis, which have strictures or Barrett's esophagus. The long term, you want to do lowest effective dose and only use it PRN if the endoscopy shows there's no damage to the esophagus, there's no functional changes. You can use H2RAs only for mild, for maintenance. And really, there's no other. You really are not, for maintenance, you're not using an acid, you're not using anything except, anything. You basically want acid suppression. So that is basically the H2RAs or PPIs, but PPIs really are the preferred. Special populations, for extraesophageal symptoms, you essentially will, for extraesophageal, you really are doing a trial of the PPI for 8 to 12 weeks, and then if there's no response, you're doing an upper endoscopy. For pregnancy, they generally will have antacids. They can use antacids. The other drug that pregnant patients can use are the sucralfate, which coats, it basically has a protective coating. So sucralfate is just one that's used in pregnancy, but not used by just everyone. And then the other one basically is really just antacids and sucralfate. They can use the H2RAs and PPIs because they are category B, but that would be something that would have to be determined by a provider. Antacids and sucralfate are very safe. Basically, really the aluminum, magnesium, and calcium, those are all safe for pregnant patients. But you really, if you want to go beyond that, you would have the provider take care of that patient. In terms of omeprazole, it is not safe in pregnancy. So just like it's not safe with clopidogrel, it's not safe with pregnancy. The pediatric patients are always going to be once a day, okay, in terms of treatment for PPIs and very short-term use. And geriatrics, they essentially, you have to really watch if they have renal insufficiency. Remember, for bismuth, for aluminum, for magnesium, etc., all of that stuff. But in terms of their dosing, they'd be once a day. They're more prone to some of the side effects because of just their age. And also, just think about it, they have decreased saliva and decreased gastric motility. So they're going to have some of these effects that are causing them to have these symptoms. And then refractory, like I said, was if you essentially don't respond to a prescription PPI for 12 weeks. That's where an upper endoscopy would be required. So, these are just more special populations that, essentially have to be looked at, that can't be just treated by, just over the counter. So in terms of the GERD case, we'll go through it really quickly here, so we can get to PUD. Basically, I have some questions. I posted the case before, but basically, she is a 68-year-old woman. She has complaints of heartburn 4 to 5 times a week over the past 5 months. Regurgitation after meals, worse at night when she goes to bed. She coughs a lot at night, which keeps her awake. Difficulty sleeping, no difficulty swallowing food or liquids. She tried OTC Prevacid, which Prevacid is PPI, as needed for the past 3 weeks. Okay. This reduced her symptoms, but they're still bothering her. So you can see she has asthma, she has diabetes, hypertension, osteoarthritis. She drinks 1 to 2 glasses of wine 4 to 5 days per week and doesn't use tobacco. She's on these meds. You can see that she's on aspirin daily and she's on ibuprofen as needed for osteoarthritis pain. The one big thing about signs you want to look at in a review of systems is you definitely want to look to see if there's any nausea or vomiting, specifically vomiting. You want to see if there's any blood, let's see, it is bright red blood per rectum. That's what that means, bright red blood per rectum. It's just a designation for GI bleeding, okay? So if there's bright red blood per rectum, then there's some bleeding going on. And so dark tarry stools will indicate GI bleeding. And then anything in terms of urinary problems. So she's normal on that, so she basically doesn't have any of those. And you can see she's 220 pounds and 5'7". And in terms of looking at her, what information indicates presence of GERD? Does she have any alarm symptoms? And what patient and lifestyle factors may be contributing to her GERD? So I have a quiz in there that has 3 questions, 2 essay and 1 multiple choice. And then you can answer those, and then we'll just sort of go through it. And then I have some additional questions that we'll just do without a quiz. And this is for completion only, so I'll go back and give you all the points. So what information is indicating presence of GERD in terms of her symptoms? Yep, 4 to 5 days a week, right? And they only reduced to 3 to 4 with the PPI. So she would be classified moderate to severe, probably. So she has heartburn, she has the regurgitation, she's got the sleep problems, the cough. So she's got a cough, so that's that extra esophageal. So she definitely has nocturnal symptoms. Does she have any alarm symptoms? No, because she doesn't have any of the pain on swallowing, trouble swallowing, bleeding, anemia that we know of. Unexplained weight loss, no, because she's 220 pounds. So, and in terms of just her lifestyle, what things are contributing to her GERD? The asthma, alcohol, overweight. And basically, what are her medications? Aspirin and ibuprofen, right? And the fact that she's a little older, you know, she definitely might have lower esophageal sphincter pressure. You know, that might be, you know, and, you know, decreased saliva in terms of bicarbonate. So all of those things, you know, because she's older, the high BMI, the alcohol, and the NSAID and aspirin, and also the asthma, definitely those are all indication, you know, risk factors for her. So what recommendation do you have? She's been taking as needed a PPI. So if she's taking it as needed, what would you recommend for her? Yeah, you would probably first optimize it and tell her to go ahead and start taking it once a day as a regular maintenance drug. That way, you know, she could see if it's working. And if it's not working, you know, after 2 weeks as a maintenance, then possibly you could switch her to another PPI to see if it, you know, helps, because they do have wide variation in that gastric pH. So you could definitely look, and then basically, you know, if she does not have any relief after 2 weeks of taking it as a maintenance therapy, then you would think about maybe referring her. In terms of what if she presented without having tried anything already? So she came to you, she's experiencing all this, what would you recommend to her? She's moderate to severe. She's like 4 to 5. You know, if you think about it, she's got nocturnal symptoms, she's regurgitating, she's got after meals. She could definitely do antacid like after meals if she's having that regurgitation. But if she's moderate to severe, what would be the most effective therapy? PPI, right? So you probably would start her on the PPI at low dose once daily, standard dose once daily, and see if, you know, if she didn't have anything, and then after 2 weeks, you know, basically see if she has a response. What if her symptoms only occurred after eating a certain food? I started talking about that already. And acid is the most immediate relief, you know, to coat, you know, basically the stomach and esophagus. So essentially, that's where antacid would, you know, definitely come into play. And if she had trouble swallowing her food, then you would automatically refer, right? Because if she has any kind of alarm symptoms, you would definitely refer. Okay, so that's just GERD. Now we'll go into the more severe peptic ulcer disease, which it's really serious because it, you know, has been shown that especially H. pylori peptic ulcer disease is the most common cause globally of gastric cancer. It's like the 4th leading cause of death. So, you know, that's something that you really, you know, peptic ulcer disease, unlike GERD, you really have to take control of it to prevent the complications. In terms of the common forms, we're going to talk mainly about H. pylori and the NSAID-induced, because those are the most common causes. We'll also talk a little about the stress-related mucosal damage, basically in critical care, because that's something that is a big incident in critical care. So the differences are, you know, essentially the critical care or stress-related is acute. It's not chronic, where the other ones are chronic. The site of damage is a little, so you have duodenal and you have gastric ulcers. The duodenum is more affected with H. pylori bacteria. The NSAIDs affect the stomach more because they're irritants that are really, irritating the lining. And then the stress related is also going to affect the stomach more than the duodenum. In terms of the pH, the H. pylori, of course, is going to be more dependent on the pH because they need a more, they need to create a more basic environment for themselves. So essentially, that's definitely going to be affecting the pH. And then in terms of, you can't really tell what is causing an ulcer. You can't distinguish between H. pylori and NSAIDs. You know that you'll have symptoms. You may have epigastric pain with the H. pylori. A lot of times with NSAIDs, you don't really know until you have a bleed, or you have an ulcer. And the same thing with the stress-related, there's actually no symptoms really because the person's in critical care. They have so many other things going on. They're intubated, they're getting enteric nutrition, or they might even have, they have IVs going, everything, machines. So the one thing that you'll see the difference is that the bacterial one is superficial, whereas the NSAID one is a deep ulcer. So it's much more damaging in terms of because it's such an irritant. And really you'll see that there's a lot more bleeding in terms of NSAIDs and stress ulcers. So you really will see that in terms of the difference in terms of trying, just when you investigate further into the type of ulcer, the types of symptoms that will be seen or signs that will be seen. So the most common causes are the Helicobacter pylori and the NSAID. The pylori really, they're essentially just bacteria that are spiral, aerobic. They colonize the gastric mucosa. They are passed in saliva, stool, contaminated food and water, so it's very, very prevalent in countries that don't have clean water. And essentially you can see that all of these in the bacteria, urease, lipase, protease, adherens, and virulence, they all produce gastric mucosal injuries. So these bacteria get into the stomach and essentially start, wrecking the stomach. They basically can lead to the ulcers, but also they can lead to lymphoma, they can lead to gastric cancers. And what happens is the lipase and the protease, they're going to destroy the mucosa of the stomach. Urease is going to produce ammonia that basically will then be harmful to the parietal cells in the stomach. So in terms of the bacteria, it has its own toxins and enzymes that essentially are breaking down the stomach lining. In terms of the prevalence, H. pylori is very prevalent in the Texas, New Mexico, and Southeast. That's where you see it in the U.S. the most in terms of seeing a lot of H. pylori induced. And then the NSAIDs, really, that is just, dose and frequency of taking and duration of taking NSAID and aspirin. It can even be aspirin low dose, depending on how sensitive somebody is. So in terms of the NSAIDs, they're reducing mucosal blood flow, they're decreasing mucin and bicarb production, so that is how they are harming the stomach contents, and they are irritants. You're going to learn more about the pharmacology of NSAIDs coming up in terms of, we're going to go through all the pain medications, so you'll learn a lot more about the pharmacology of NSAIDs. These two together can be extremely additive in terms of risk factors. So if you're taking ibuprofen or even low-dose aspirin and you have H. pylori, you're probably going to get some type of an ulcer. In terms of the clinical presentation, you can see that essentially you can have either mild pain, like you saw, some of them were asymptomatic, right? So you can have mild pain or acute life-threatening depending on the complications. The big thing with gastric ulcers, which is basically more the NSAID and the stress, is weight loss, nausea, vomiting, and anorexia, okay, because it's a gastric ulcer. Abdominal pain that is epigastric, burning, you have more than just belching, bloating, and heartburn. You basically are getting a lot of pain in your abdomen. And you're definitely waking up at night, okay, in terms of nocturnal pain. It's not just symptoms, it's basically pain that's waking you up. In terms of the complications, this is why you really have to treat as soon as possible. You really, really want to prevent upper GI bleeding, okay, where the ulcer goes into an artery, and NSAIDs are the biggest, problem. Perforation goes into the pancreas, the biliary tract, or the liver. And then also obstructions. Even if you have, a duodenal ulcer, you're going to have like duodenal narrowing. So you're going to have actual mechanical obstruction with scarring. So in terms of duodenal, the only way you can sort of tell the difference between duodenal is generally you get pain 1 to 3 hours after meals, and sometimes meals will alleviate the pain. Whereas with a gastric ulcer, food is actually going to trigger that pain. So that's the only way to really tell the difference between the two. In terms of treatment, you can see the goals. You're going to eradicate the H. pylori infection, and you're going to stop the NSAID. That's the biggest thing. Non-pharmacologic, you really are just taking out the causes and also reducing some of the risk factors, and also avoiding, along with, taking out either the bacteria or the NSAID, you essentially are going to avoid things that give you that dyspepsia. So same thing that causes GERD, avoiding all the same type of triggered foods and medications, etc. So this is just a treatment algorithm. You don't need to have, memorize this or anything. This is basically showing you, first, the big thing is you want to, first of all, make sure that there's no alarm symptoms, and then also, are they on an NSAID? And that's an easy thing. If they're on an NSAID, that's the biggest thing to take out or consider co-therapy with a PPI, because people might not be able to be taken off of an NSAID. Or aspirin, same thing. They might not be able to be taken off because they have, a protective effect. That's where co-therapy might be necessary. You can see that essentially if there are alarm symptoms, things like the bleeding, the anemia, the weight loss, all of that, that basically will then, have you do an endoscopy, and then you're definitely testing for that H. pylori, okay? The H. pylori is the biggest, it's really one of the biggest causes. We'll go first because NSAIDs are pretty easy in terms of how they're treated. These are the risk factors for NSAIDs, so, older, because they basically have more medications. They also will have chronic debilitating diseases. Some of the diseases, things like COPD, cardiovascular, cirrhosis, chronic kidney disease, all of those things will predispose somebody with NSAIDs to possibly have more risk for an ulcer. High dose and multiple use. COX-1 inhibitors, they are the non-selective ones like ibuprofen are COX-1 and COX-2. The COX-1 is the one that causes all the adverse effects, whereas the COX-2 is going to take care of the anti-inflammatory. So those two receptors, etc., that is why the COX-2 are preferred in people that are at risk for ulcers, because they are really getting the anti-inflammatory effect without all of the adverse effects. In terms of the, other risk factors, any of these drugs that are used alongside NSAIDs will increase that risk factor. The ulcer treatment and prevention, okay? You're going to discontinue the NSAID if possible. You're going to do an 8-week regimen. So remember, 8 weeks for empiric therapy. PPIs are preferred, okay? It's extended to 12 weeks, and you're going to be using, I'm going to talk about misoprostol if the NSAID has to be continued. So if it has to be continued, you can't take them off, you're going to have some co-therapy to prevent damage. You really want to have a selective COX-2 inhibitor if you can, and you'll learn, I didn't go into the difference between the two because you're going to learn that in pharmacology. in terms of the next lecture for the NSAIDs. And then in terms of, one thing you might think of is acetaminophen instead of NSAID, or like salicylate or trisalicylate, the non-acetylated salicylates. The H. pylori should be performed because you want to make sure there's no H. pylori because it is an additive risk factor. For prevention, like if you have to be on an NSAID to prevent an ulcer, then basically you're going to have co-therapy with PPI, H2RA, or misoprostol, which basically that is really prostaglandin. And remember, prostaglandins are really good in terms of, anti-inflammatory effects and protection. They basically will protect more than cause damage. Decreases the complications, but essentially that is sometimes used along with an NSAID if they have to be on it long-term to prevent damage. In terms of the PPIs are preferred because H2RAs are less effective. And in terms of really NSAID use, you have to just use the lowest effective dose possible and the shortest duration. Now, for H. pylori testing and treatment, these are the indications for H. pylori testing and treatment. The three in red are absolute. If any of these are in a patient, peptic ulcer disease, prior active, which is mucosa-associated lymphoid tissue lymphoma. I have that in your notes. But basically, it's a specific lymphoma that is definitely associated with H. pylori and ulceration, and essentially that, and then primary and secondary prevention of gastric cancer. So if any of these people have any of these indications, you're going to be testing for H. pylori. Some of the others are essentially, dyspepsia without alarm symptoms, if they're taking long-term NSAIDs, if they have anemia that's not explained, they have thrombocytopenic purpura, which can cause bleeding because basically you have a lack of platelets. And also, all people who are tested for H. pylori are going to be treated. Okay, it's not just testing, they are going to be treated. And then after they're done with their treatment, they have to go through diagnostic testing screening to make sure that there's a cure. So they essentially will get, after 4 weeks, because you have to actually stop the PPI 2 to 4 weeks before actually testing for H. pylori. So essentially they'll go through a test, first of all, to make sure that H. pylori has been eradicated and, essentially make sure that there's a cure. You don't have to worry about the testing. These are just the different tests that are used, endoscopy and also non-endoscopy. The interesting thing is you can't really do serologic tests for somebody because months and years later, they still have H. pylori in their blood. So, those are not as effective. So that's why they use the urea breath test, which is here, fecal antigen, sometimes biopsies, to make sure that they have a cure. The one big thing about H. pylori is antibiotic resistance. So you have to ask them about their antibiotic exposures. And like I said, you have to wait 2 weeks at least after discontinuing the PPI to actually test. These are just some of the sensitivities and specificities just to see show how good they are at detecting H. pylori, which you don't have to memorize. And these are the antibiotic resistance rates. This is why you have to make sure you know if it's antibiotic sensitive. Because you can see here how large, 22.2% overall resistance for clarithromycin, 69.2% for metronidazole, and it varies, around the country. But you can see that levofloxacin is another one at almost 40%. So you definitely don't want to enhance antibiotic resistance by treating people that are not sensitive, treating bacteria that's not sensitive to that antimicrobial. So these are the regimens. I don't expect you to, you know, I'll show you the different regimens specifically, but I don't expect you to, you know real details. I'll tell you exactly what I need you to know. But the regimens are for 14 days, okay? 10 days, the effectiveness decreases by 10%. So you definitely are treating for 14 days. Treatment naive or anybody who has never been treated for H. pylori. Treatment experienced are people that have persistent infections, okay? And then you have to think about penicillin allergy because some of these contain amoxicillin. Optimized bismuth quadruple is the one preferred therapy. Just, you know that, definitely know that. It's used in basically all of these indications. The second preferred is rifabutin triple. Talicia basically is the brand name for the product in the United States. And then in terms of these others, there's a new potassium competitive acid blocker, vonoprazan, which is Voquezna. There's two products, triple and dual therapy. And essentially those, it's a better PPI. It basically is going to inhibit acid secretion even further than a PPI. Better duration, better response, everything. It's a little more different than the mechanism of the PPI, but essentially it has become, it maintains the intragastric pH greater than 6, a lot longer. So that basically, and then levofloxacin is sort of like a low down preference. But these are just the different types of therapies. I don't want you to know the actual doses and frequency, but I do want you to know for this treatment naive patient, I want you to know what's in the actual product, okay? So essentially optimized bismuth, you are going to be, what it actually is the bismuth, the tetracycline, and the metronidazole, and they are actually contained. We have actually two products in the United States, Pylera and Helidac therapy, that have that bismuth subcitrate or subsalicylate. They have the tetracycline and the metronidazole all in like a 14-day therapy. Very expensive. Pylera is $730, just regular wholesale for 14 days. So they at least combine them into, less tablets so that essentially, and you can have like a set regimen. Then you still take a PPI BID plus those drugs. Rifabutin, that is that Talicia. It has omeprazole, amoxicillin, and rifabutin. The Voquezna dual pack and triple pack, that has vonoprazan, which is the PPI, potassium competitive acid blocker, and amoxicillin, and then clarithromycin. And here, the biggest thing is you want to reserve the clarithromycin for patients that are clarithromycin sensitive in terms of the bacteria. If they've had clarithromycin before, they'll give them the dual pack. They won't give them the triple pack, okay? 10 days is not approved by the recommendations. The FDA doesn't approve like the separate components, but it does approve these combined approved. But 10 days definitely is not successful. This is just to show you treatment experience. I don't expect you to know this in terms of the treatment experience. Just I wanted you to see if somebody has persistent H. pylori, then essentially after they've been treated once, then this is basically what they will go to. They'll still go to that optimized bismuth quadruple therapy, and then rifabutin triple is another second line for people that have persistent H. pylori. And this is what the Voquezna actually looks like in terms of their therapy. You can see 2 amoxicillins, and let's see, and then 1 clarithromycin and 1 vonoprazan. So that's basically what it looks like. Okay. Here are all the side effects. Lots of side effects. So basically, I definitely want you to know this slide in terms of the side effects. Sorry, I'm running late. If you can just there's no, information outside of this, but essentially know the side effects for the different medications, because they definitely, side effects and adherence are a big problem with this antibiotic resistance and also eradicating the H. pylori. Lastly, the stress-related upper GI bleed. Essentially, it happens within 1 to 3 days. These are the risk factors for prophylaxis with the PPI, coagulopathy, shock, chronic liver disease, and any neurocritical care. So if they have any kind of neuro care, they're going to be on one. And they basically are going to be using really the PPI or H2RA. PPIs are preferred. They're either enterally through the feeding tube or IV, okay? And then once they're taken out of the ICU or the risk factors aren't there, they stop them. They don't continue them on PPI. So it's really acute just for those patients that essentially have, a risk for that upper GI bleeding, okay? Which is 75% of patients in critical care, okay? All right. Thank you so much. Sorry for going a little over. Have a good day.
That was